I wanted to welcome everybody to ABODE Academy 3. I'm Mary Thorsby, the Executive Director of ABODE Contemplative Care for the Dying. And thank you so much for joining us tonight for Hospice Is It Time? And this is part of our series on care for the caregiver, refilling our cup. We kicked off ABODE Academy last summer, so this is the third round of it, and we're just so pleased with it. I think most of you know that our mission is to take care of folks at the very end of life, their last 3 months, 3 weeks, or even days. And we partner with their hospice agencies and love them up until they're ready to go. And we do that here in our beautiful home and at no charge. So we are run strictly on donations and grants. It's just a wonderful ministry and service to the community that folks can come here and be cared for and pass away and not have to worry about anything else. But just as importantly is our community education and outreach. And we have definitely beefed that up over the past year or two, and that's very much in no small part, a huge part, due to Beverly Tuomala, Christus hospice nurse. So she is on our board of directors, and she's our education committee chair, and we all work together to bring these great programs to our community. So we're absolutely thrilled to have you here. Before I turn the program over to Beverly, I want to do a quick plug. If you're ready to volunteer, we're ready to have you. If you're vaccinated, we'd love for you to start coming back to the house. We have 101 fun things for you to be doing. So if you have any interest in that, just send me an email, mary@abodehome.org. We're doing a staff and volunteer training session on Friday, August 20th and Saturday, August 21st. So we'd love to have you play a role in that and get you back in here. We miss your spirit and your energy. We're ready for you. Tomorrow morning, I'll send out a survey. It's very helpful if you fill it out to tell us what you thought of tonight's program. It helps us with our planning, and it also helps us with our grant applications. So I'm going to mute all of us and turn it over to Beverly. And if you have any questions, please use the chat box. I'll keep a watch on those, and we can cover all questions and suggestions and such at the end. By the way, Beverly was voted best hospice nurse in all of San Antonio recently. So we are very lucky to have her with us. Beverly, take it away.
I don't know what I did to deserve that honor. I see these folks and I love them out of this world. And I'm just honored to be doing what I do. I've only done hospice for 5 years, but my entire nursing career has been in preparation for this. And I remember when I first was in nursing and started doing critical care. And I always just told everybody, well, when I grow up, I'm going to be a hospice nurse. And that's what I do. And it's not work. I get to go and see these people every day and just build relationship and take care of them until they move on. But so tonight we're going to kind of talk about hospice and what it is. Hospice has a lot of myths with it. Many times I get people as we're admitting them and they have no concept really of what we're there for. And so a big part of what I would like to do with this program is to just let everybody know what it is we really do. And the more the community knows what we do and how we do it, more people will come to hospice care. Because as we all know, the hospital is no place to die. You know, it's so much better to be in your home, surrounded by people you love, smells that you know, sounds that you're familiar with. And as you know, being in a hospital, it's cold, it's very stark, it's loud, and people are in and out. Where in your home, it's a place of familiarity and it's a place of love. But the concept of hospice has not been around that long. I don't think I was taught anything about it when I started nursing school. And but the concept of hospice really didn't start until the 50s. There was a woman in England. Her name is Dame Cicely Saunders. She was she was a nurse first, and then she became a doctor. And she started the first hospice back in 1967. So it took her a long time to kind of get the concept and then build it. And she did that just knowing that people were dying in the hospital, and she knew that was not the place for them to die. We didn't start really getting that concept here in this country until a book by Elizabeth Kubler-Ross came out, and she interviewed a bunch of dying patients, and the book is called On Death and Dying. And she interviewed a lot of patients at the end of their lives, and kind of realized that people didn't want to be in the hospital. They want to be nurtured and loved at home. And so she took that plea and just pushed for home care versus hospital care. So in 1974, they founded the first hospice here in the United States. So 1974, and that was in Connecticut. And then in 1978, the concept started getting around to Medicare, insurance companies, that it was kind of a viable thing at the end of life, and that it would save money. And that's what the key was, because they found that hospice would save a lot of money. So in 1982, it finally became a Medicare provision. So, that's pretty recent. And it's now a benefit of your Medicare Part A. So if you've got Medicare A, you've got a hospice benefit. And what happens when you come on hospice with Medicare, we as a hospice take all of those Medicare dollars to take care of you. And Medicare pays the hospice a daily rate, a per diem, to take care of you. And what do I mean by taking care of you? So hospice is medical care to help someone with a terminal illness live as well as possible for as long as possible, increasing their quality of life. We're not in the business to make people better. We're not in the business to treat people. We are in the business to provide medical care that will make their quality of life better. We use a team approach. We treat the physical, psychosocial, and spiritual needs of the patient. So every hospice, when a patient comes on board, they have a nurse, and they have a doctor, they have a chaplain, and they have a social worker, and they have a home health aide. So the doctor oversees our care. I call Dr. Yang Kim on the phone all the time and go over things with her, and she directs what we're going to do. I'm the nurse, and I implement it in the home. I do all the teaching and teach my patients or their families how to take care of their loved one. We're going to talk about myths later in the program, but one of the big myths is people think that when we come in as hospice, that we're going to stay with you. And we don't stay in the home. Years ago, we used to, but Medicare no longer pays for that. So our job is big. We've got to get our families ready and educated to take care of their loved one. And so our focus is really symptom management. If they have pain, we treat pain. If they have nausea, we treat nausea. If they've got tubes and drains and things, we manage those as well. And then, of course, the chaplain comes in and provides spiritual support. Our social workers come in and, kind of put their social work eyes and do the legal things, help with living wills, help with do not resuscitate orders. If placement needs to be done, if the home isn't safe or they can't take care of their loved one, then our social workers help us find someplace where we can put them, like ABODE. And so we do all these home visits. We'll also provide all the medications that this patient needs. And many times we like to start removing meds because patients come out of that medical model where they've got 30 bottles of pills, and nobody who wants, who's lacking appetite and they're nauseated wants to take 30 pills a day. So we start weeding through what's important and what's not important and get them down to the nitty gritty. We provide all the medical equipment as well. So we will bring in beds and bedside commodes and wheelchairs and walkers and Hoyer lifts and shower benches, all of those things. If you can think of it, we'll try to get it in the home. And we also have some modified physical therapy that can be brought in. And it's not for rehab. Our physical therapy is for safety. Our physical therapy teaches our families how to transfer from a bed to a chair, how to pull people up in bed and manipulate them so that, they don't get hurt. And then we also can provide some dietary counseling. And I've not done that much, but like some of my folks that have a lot of nausea, or folks that are on tube feedings and they're not tolerating them, we've consulted a dietitian that gave us some guidance. Hospice can also provide, which a lot of people don't know, we can do short-term inpatient care for symptom management. So if I admit someone and they have intractable pain, and we've just tried every pain medication we can think of in the home, but they're still very uncomfortable, or if they have nausea that we can't get rid of, we can put them in the hospital for a short stay until we get those symptoms under control, and then we bring them back home. And we will do all of the pickups and all of the deliveries, and try and make it very easy for our families. And then we also can provide a short-term respite care to give our caregivers a break, because it is a lot of work. And this is why we're doing this program tonight, is being a caregiver is probably one of the most difficult jobs anyone will ever have. And there's a lot of burnout. And probably a good portion of my visits is spent with the caregivers because they're lonely, they're sad, they're scared, and they're overwhelmed. And if we start seeing that it's just getting to be too much, we can offer this short 5-day stay someplace that we designate, and we'll take care of them, and our caregivers can get some rest. And they can do this once a month if they need it, which is a wonderful benefit. And then hospice also provides grief counseling. So once someone is passed, their family stays in our care for 13 months to receive grief counseling and bereavement care. And so a lot of people don't know about hospice. They just think we come in at the end, and when hospice shows up, we're going to die. But I've got people on service that I have a lady that I just visited. We're almost 5 years. But she continues to be recertified. She continues to show decline, but we've got a wonderful relationship. I know her and her family like, they were my family. And that's wonderful, because when the time comes and she begins to start actively dying, that trust has been developed. They look to you for comfort, and they look to the nurse and their team, that they know their whole team. They can support them. And all too often, many of our patients come on and they pass within the week because their families were afraid of hospice. Hospice means we're dying. Hospice means that they're not going to be here very long. And that's not the case. The sooner you can get someone on hospice, the better, because we can provide a lot of care, a lot of support, and get the most out of the benefit. So that's what I have to say about hospice. And I'm going to introduce Dr. Yang Kim. She's my medical director, and I get the joy of calling her on an almost daily basis to get guidance on how to take care of my folks. And she makes home visits. And so if I call her and say, Dr. Yang Kim, Mr. So-and-so, their family is really concerned about this or that. Can you come make a visit? And she will. So, the doctor makes home visits. Dr. Yang Kim obtained her undergraduate degree at Columbia University in New York, attended medical school at Kirksville College of Osteopathic Medicine in Missouri. She completed her internal medicine residency at Kaiser Permanente in Santa Clara, Northern California, and her geriatric medicine fellowship at Stanford. She's a board certified internal medicine doctor, a geriatric medicine doctor, so she's board certified in those. And also, which is very unusual, she's board certified as a hospice medical director. So we're so lucky to have her. She's been honored to be a hospice medical director for many years and serves as the hospice and palliative medical director for Christus Hospice and Palliative Care. She's very passionate about providing and promoting the quality and dignity at the end of life. And she's so gentle and she's so wonderful. And so, Dr. Yang Kim, you will take it away.
Thank you, Bev. I'm honored to be here to speak with everybody about hospice and palliative care as well. And I just want to say that it really is a wonderful area of medicine that is becoming more prevalent and known in, amongst a lot of people nowadays, which is great because I think we needed it. We need it to be known more because it benefits so many people. What I wanted to talk about with you today is just tell you, first off, about how physicians determine whether patients qualify for hospice or not. So one of the things that Bev mentioned is that hospice is primarily, a Medicare benefit. And they have said it so that usually our patients have a prognosis of 6 months or less to live. And this benefit isn't just given by Medicare. I mean, a lot of private insurances offer hospice. Programs like the VA definitely have a strong hospice and palliative care program as well. So it's not just limited to people that are under Medicare. But generally speaking, our patients are felt to have a 6 months prognosis or less. Now, I'm not God, and so, physicians cannot predict completely accurately that it's just going to be 6 months, because as Bev mentioned, often our patients end up living longer on hospice, and they graduate off of our hospice program. And, sometimes our patients end up dying prior to the 6 months life expectancy. But that's a general consideration that we as physicians look into. And so how do we determine that? Well, there's general criteria that we look at based on the different disease processes that our patients have. So there's different criteria for somebody that has end-stage heart disease versus end-stage lung disease or end-stage kidney disease, for example. But if somebody does not, so for example, if somebody has end-stage heart disease, then we may be, when we're asked to look at the patient and see if they qualify for hospice, we might look at things like, is our patient or is this patient or your loved one experiencing a lot more shortness of breath than they were a couple months ago? Or are they going back and forth to the hospital a lot more frequently than they were before? Or somebody with Alzheimer's dementia or just dementia in general. As a physician, I may, look at, has our patient or has this patient lost a lot of weight or, had much more falls recently than before. So these are just some general guidelines that we look at. Now, if our loved one or, our patient does not qualify under one specific diagnosis for hospice, that's okay, because we understand that there can be a lot of disease processes going on. So for example, if your loved one has fallen a lot in the past couple months, or is needing a lot more assistance with the normal activities that they do at home, such as bathing or dressing or toileting, then those are things that are showing us, and your medical team as well as your family that there's some sort of disease process or clinical decline going on. And all that put together could suggest a possible prognosis of 6 months or less to live. So we don't focus specifically on one disease, but we focus kind of on the big picture and how much has our patient declined over the past couple months or couple years. So then the next thing that I wanted to talk about is hospice myths. Oh, sorry, before I go back to that, if you're ever unsure, if somebody's unsure whether they qualify for hospice, then the best thing to do is to call a hospice and talk to them, and they can send out a nurse or somebody from their team, a physician or a social worker, somebody to come and evaluate the patient and talk to you and give you some guidelines, and not guidelines, but give you some suggestions on whether it's time for hospice or not. So I wanted to also just go over some hospice myths that Bev had talked about. So the first thing is the first myth is hospice is a place. So hospice is not a place. I think a lot of people have come to that, have thought that it is, but it's a benefit, like Bev had mentioned. It's a benefit that can be provided in the home or in the nursing home or assisted living, wherever your loved one lives. Another myth is it's best to call hospice at the very end. And as Bev mentioned, it's better to call hospice earlier. There have been many studies that have shown that patients that go on hospice earlier actually tend to live longer than they would have if they had not called hospice and had focused on getting more aggressive care. And that's because a lot of it is because they have better quality of life when your loved one is at home, or at the very end, our patients cannot benefit from the wonderful team, the hospice team, that can help our patient and our loved ones out at the very end. There's a lot of it's very difficult to be a caregiver. So to have that extra layer of support that hospice provides is very helpful for our families as well as for our patients. Another myth is patients on hospice have to give up their primary care physician. So a lot of people think that they cannot see their doctors anymore while they're in hospice. So that's not true, because your primary care doctor or our loved one's primary care doctors can continue to manage your loved ones or our patients' medical care. I work alongside with the primary care physician to help treat our patients. So you do not have to give up your primary care physicians on hospice. And then the last one I wanted to mention is hospice is for when there is no hope. And that is not true. We try to maximize quality of life as best as we can, but we, give oral antibiotics if there's an infection. We try to do as much as we can in the home to help our patients be comfortable and to have a good quality of life, and to maintain as much alertness as they can, so that they can spend as much time with their loved ones as they can. So we, as Bev mentioned, sometimes we have nutritionists come out to the home, or physical therapy. We work with every person, and we try to meet them and their needs. And so the last thing I wanted to talk about is, what is the difference between hospice and palliative care? We get that question a lot, and it can be a little bit confusing. So palliative care is similar to hospice, but it's different in some ways. Palliative care, in order to be on palliative care, you do not have to have a life expectancy of 6 months or less to live. It's a specialized form of medical care for people with an advanced, serious, and or life-threatening illness. So patients can receive curative treatment for their conditions while they're, alongside receiving palliative care. Palliative care can be provided in the home, it can be provided in the hospital. We have palliative care teams that work in the hospital to help the specialists or help the other physicians and help provide that quality of care that patients can benefit from while in the hospital. Palliative care can be given in the outpatient clinic setting. Palliative care often involves a team approach. So in Christus, I work with our wonderful nurse practitioner, Greta Mann, and we see our patients together, we take care of them together, and we work with our social worker, our chaplain, bereavement counselor as well, if our families or our patients need their help. So it's wonderful to also have that team approach like we would in hospice. And one of the main things that we treat in palliative care, like in hospice, is we try to help to relieve the patient and the family's distress from dealing with any emotional distress or social issues, and definitely with any symptoms that our patients are experiencing. So for example, we are often seeing our patients because there may be very difficult to control pain that the patient is undergoing, or they're having a lot of anxiety, or just spiritual issues or emotional distress. For example, I had a patient recently who had pancreatic cancer, but he wasn't yet ready to give up his chemotherapy. So Greta and I were taking care of him in his home and helping him with treating his nausea. He was having extreme nausea, and we were there for him. And the benefit of palliative care is that patients don't have to go back and forth to see the physician for any symptoms that they're dealing with. We can go see them in the home, because it's often very difficult for our loved ones or for our patients to travel back and forth. So that's an extra benefit. So just wanted to let you know it's an extra layer of support basically for our patients as they're living through their advanced illnesses. So that would be it for what I would like to discuss, but
That
we can
have,
answer any questions.
yeah, thank you both so much. That was fantastic. If you've got questions for either of our fabulous speakers, just use the chat. Do you need a doctor referral to be eligible for hospice?
Yes, well, you can have a doctor's referral. Yes, that's often the case. But families here in Texas, families can often call hospice themselves and try to be admitted to hospice have their loved one be admitted to hospice. So it's state by state dependent. But here, yes, families can call themselves.
So if that happens, if the family calls, and you agree to accept the
Mhm.
patient, how do you then interact with the doctor? Do you reach out to the doctor?
Yes, definitely. We have a fabulous team that we work with in the office, and so they'll call them, and then I myself will call them personally, sometimes to let them know, especially if they have a very close relationship with our patient. Then yes.
And I can't imagine that the doctor would disagree or not be in favor of this extra care. Does that ever happen? That,
Not usually. Usually, it's more on the part of our patients or their loved ones who aren't quite ready yet for hospice.
yeah. Well, I've got a question about that here too. The next question, I think you answered part of it. If a patient is on hospice, can they still see their doctor? And you said yes. Um, or can they go back to the hospital if something happens to them and they're on hospice? Can they go back into the hospital?
Yes, they can. And and it gets kind of muddy, but the answer is yes, they can go back. And then we have to decide if they need to come off service and stay. If they're going to stay in the hospital and be treated, we definitely have to take them off service because we need to give them back their Medicare dollars to pay for the hospitalization.
Right.
And so we call it a revoke, and we take them off service. And then once they, do what they're going to do in the hospital and go back home, we can certainly put them back on hospice again.
Yes, I remember with my mother, our first call would have been to hospice before calling
Yes.
911
Yes.
in order for you to take her off hospice.
Yes. And
Okay.
sometimes people forget, they panic and they call the 911, and
Yeah.
and then they'll call us, and then I go out and I've pulled in right behind the ambulance. And then we have this discussion, are we going to stay or are we going to go? Yeah. So it can
And
get pretty
often
scary.
yeah. And it's wonderful you mentioned that, Bev, because often it just, once we are able to talk to our patients or their loved ones and explain what going to the hospital means, and the consequences of going back, like sometimes the aggressive treatment that they might receive in the hospital might be very, um, much more difficult and have more side effects than if they were to be kept, to stay at home. Then a lot of times our patients end up deciding, oh, okay, it's just actually better if I stay at home instead of go back.
And even at that point, let's say that did happen, and I was the nurse called out. That visit could take a very long time, to just calm the patient, calm the family, and get them comfortable again with whatever event happened. Whether it was a fall, or if they just got scared. Hospice we have the time to be there. If I needed to stay 2 hours or 3 hours, I could do that. We could do that. So,
Okay. Yeah, on the subject of folks who are not ready to accept their dying, can you offer some ways that loved ones can broach the subject um, for hospice, knowing that their family member is adamant against it?
Yeah, so a lot of it is explaining to our patient or the family, but if you're talking in the situation, the patient, about what it means to continue aggressive treatment. Because oftentimes our patients may think, okay, yeah, I want to go to the hospital. I want to continue doing everything. But then we, even we ask them, what, what do you, like, are you okay with going back to the hospital and um, getting the surgery? Do you want to go through the rehab and all the things that go along with that? Do you want to continue dialysis and have to make these frequent trips back and forth to the dialysis center, especially if you've been having a lot more weakness and having a lot more difficulty tolerating, the dialysis. So, we sit down and try to explain the consequences of every treatment that our patients receive. And, a lot of times our patients may say, yes, that's what I want. They understand completely what it means. And that's okay. They may not be ready yet. The loved one may be ready, but our patient may not. And that's okay because we want to honor the wishes of our patients. So that's the benefit of palliative care and hospice, which is what Bev mentioned. We can sit down and help our patients and their loved ones have these conversations. And it's better to have them earlier so that the burden isn't placed on, the families to make these difficult decisions.
and often this is always a fun thing to get into. Half of the children want hospice, and the other half don't. And we walk into that situation more often than not. And then another one I love is the family will put their loved one on hospice, and then and many times they are able to sign the consents and everything, but they'll say to me, well, don't tell them that they're on hospice, just tell them you're like a home health nurse. And I'm my name tag says hospice all over it. And then I'll go in and see the patient, and they'll say, my family doesn't know that I know, because they're just afraid to have that conversation. So yeah, we get some very interesting situations out there, but it's very interesting to walk in and have half of the room not want it and the other half want it, and be looked on as the Grim Reaper, because the ones who don't want it think that we're hospice shows up and oh, dad's just going to die. You're just going to pull that morphine out and they're going to die. And that's a huge myth that, we bring the morphine out and it's over.
Right.
Yeah, we try to provide that quality of life, treat the symptoms that our patients are going through, but we want them to, be as cognizant and as alert as they can tolerate as possible, so that they can interact with their families or their loved ones.
So can patients still get chemotherapy and aggressive treatment while they're on hospice? I know you probably don't recommend it, but if they really want to.
I would say, generally speaking, we don't. It's usually considered to be more of aggressive care, and usually they aren't continuing chemo and things like that. However, there have been instances where our patients are receiving radiation to help treat their pain, their uncontrolled pain that they're having. So yes, we will be able to admit our patients if they're having palliative radiation. So it's case by case dependent.
Okay. How about a do not resuscitate? To be on hospice, does your patient have to have a do not resuscitate form?
No. So that's another myth. That's a big myth. No, they do not, because we understand that that's a difficult decision to make. And so they do not have to. We have a lot of patients that are still full code. But, after a certain period of time, they may have become a lot weaker and have a lot more pain or symptoms and they end up changing their mind and not wanting to be resuscitated anymore. So we're constantly talking to our patients and their loved ones about the process and dying and what their wishes are, because it changes.
Yeah, along those lines, can your patients go off hospice and then come back on later?
It can. We do that every day. Patients will either decide that they want to go back to the hospital or they want to go back to their doctor, and we can take them off service and they can come back on when they're ready. Some patients we can transfer to another hospice. If, let's say, they lived with the son and daughter here, but now they want to move to Dallas, and we can discharge them from our hospice and transfer them to another hospice. And yeah, and then also if a patient, we call it, it just left my head, extended prognosis. So if somebody comes on service, but they got that hospice effect, they start feeling better and doing better, and we just did not see decline, and that we're just not really doing anything except a social visit. And we'll watch them for a period of time. It's not like a decision made right away. Our teams, your hospice teams, we meet every other week, and we sit with the entire team and the doctor, and we discuss each patient and how they're doing, how they're progressing, and how they're not progressing. And again, we're opposite. They progress, meaning how they're declining, and they're not progressing, meaning they're kind of stuck, not doing anything, or maybe they're getting better. And if that's the case, we will take them off service. And then if they decide to come back later, once decline starts again, then we can readmit them.
Good. Oh, here's a good one from Mary Lynn. Why doesn't palliative care automatically happen? Does a patient or family have to request palliative care?
That's a great question. So it is becoming a lot more common and prevalent. And it is something that sometimes physicians are well versed with palliative care. They know all about it, and so they will automatically refer patients. But I would say a lot of times physicians may not be that familiar with the benefits that palliative care can provide, or they themselves have misconceptions about palliative care too. They think that it just means they're giving up on their patients, and so they may not refer to palliative care. But um, usually you have to have an advanced life-limiting illness in order to be on the palliative care service. So if somebody has like chronic pain, that may be something more for a pain management specialist, instead of going towards palliative care just to treat the chronic pain. So usually you have to have the life-limiting illness. But I think it would be great if a lot more doctors referred to palliative care. That would be great because it can benefit so many people.
Yeah.
What's the most common diagnosis you see in palliative care?
I would say heart failure is one of the most common, or end-stage lung disease is very common as well, and cancer as well.
How do you respond when a family member believes that removing life support is killing their loved one?
Ooh, that's hard.
Yeah. I would say that I would explain to them that it's not the life support, per se. Your loved one or a patient has a disease process that's actually causing him or her to decline significantly. And then, you know, probably talk to them more about what their fears are about removing the life support, because a lot of times um, somebody may have not misconceptions, but may have had a bad experience with hospice with another loved one that they've helped to take care of, or they just, maybe do not know that continuing that aggressive treatment has side effects as well, and could cause more pain and suffering for their loved one. So we would sit down with the patients and families and explain that and talk to them about that.
I've had a couple of unusual circumstances the past few months where I went to the hospital and had to be present while they took a breathing tube out of a patient and and put them on hospice. And so we were kind of there for support and to ease that patient into hospice care. It's a very unusual circumstance, but a lot of times the patient's family is really kind of in turmoil, and am I doing the right thing? And one of the questions or statements I give them is, do we want to prolong their life, or do we want to are we prolonging their life, or are we prolonging their suffering? Because we can surely prolong their life. We can keep them on a ventilator for days and days, but then we prolong their suffering. And but yeah, it's a very tough thing to talk about.
Well,
And I think, oh, sorry, go ahead.
that leads to the next question. As a doctor, why do you believe that some doctors are so hesitant to discuss the option of hospice with patients and their families?
I think we're trained as physicians to help cure our patients, and we're trained with giving them aggressive care, but hospice and
Yep.
palliative care has become much more in the past couple of years, so pretty recently, much more common than before. So I think the tide is changing, but I think a lot of physicians may not have had loved ones on hospice, or no, they have not actually referred patients to hospice, so they don't know about that extra layer of support that we can provide. And so they also think that they're giving up on their patients, and that's the end, I'm never going to see them again, or things like that. But no, we're just there, if they want to continue to be the primary care physician, then that's okay. That's great. We can work with them.
Mhm.
So I think it's changed.
Will hospice help a family make the decision to move to assisted living if it is apparent that they are not doing, if it is apparent that they are not doing well at home?
I'll take that one. Yes, that happens a lot. And we'll have people in the home, um, in whatever environment. If we see that it's not working out, that the caregivers are overwhelmed, or let's say even a patient's in assisted living and they're falling all the time. Um, Dr. Yang Kim mentioned falls. I mean, that is a huge bad prognosis when we have fall after fall. And assisted living, they're able to move around a lot more and there's not a lot of supervision. So as a hospice, it's our job to kind of come in and kind of have a team conference and say, this patient needs a higher level of care. Or if a family's at home and they can't take care of somebody, to talk about moving him to a nursing facility or a personal care home. That's part of our job as the team, and to help families make that decision and give them options. And our social workers do a wonderful job explaining each level of care, and what that's going to cost, and how they can support that, and what their dollars and their insurances will pay for. These social workers are full of wonderful information. I've learned a lot from them.
Here's another question about palliative care, and let's just see if you have anything more to add. So, would I choose palliative care if I wanted to continue treatment for cancer or heart disease?
Yes, definitely. You can choose palliative care because if you're having any symptoms that you're experiencing, we can help. As a palliative care doctor, I can also help to manage that, or other physicians as well. And we will be in contact with, we regularly keep in contact with oncologists and other specialists or primary care physicians. So yes, it's great. And our nurse practitioner is wonderful. So she also provides wonderful support for our loved ones. I mean, for our patients as well. So if our patients have any questions about completing DNR orders, or when do I want hospice or do I not, we'll have that conversation and help our patients.
And it's a wonderful
Um,
team, that teamwork that happens, because Greta, or a palliative team, would kind of help the patient ease into hospice if they're just not ready. And so it's a
mhm.
wonderful bridge to get them there, right? Yeah.
This is a good one about choosing a hospice provider. When choosing a hospice provider, are there any suggestions on questions families should ask, or what recommendations would you give on choosing a hospice provider?
Um, I would say, in general, hospices all provide the same stuff. Um, we all have the nurses, the chaplains, the doctors, the social workers. Um, but word of mouth is real good. If a family member or friend had a good experience with a hospice, that would be a good way to choose. Um, Another one is, conduct interviews. A lot of times a patient is ready to come and they've put the referral in, and then we'll go and talk to the patient and find out that we're interviewing 5 hospices today. And so we're part of the lineup. But yeah, interview them and see, kind of, what your thoughts are. um, but some great questions that I think are good is ask about response times. If if my dad has an event on a Saturday, how long is it going to take for your nurse to come out? How many nurses are on after hours? Is it just one? Is it two? You know, San Antonio is a big city. And so what is your response time after hours? Um, how quickly can we expect pain and other symptoms to be managed? You know, are you going to be able to get drugs here today? Is somebody be able to come in today and teach me how to use them? You know, those are really great questions. And then how often will team members visit? You know, can I expect a nurse visit every week, every 2 weeks? Am I going to see the same nurse? That's really important, I think. Continuity of care is really, really important. And I think, you know, number one question, am I going to keep the same nurse throughout my experience? What do you think, Dr. Yang Kim?
I completely agree with you. Yeah, I definitely think just talking to as many people as you can, word of mouth is very important with choosing a hospice. And all those things that you mentioned, I completely agree.
Good. Okay. Can you help us understand the difference between for-profit and non-profit hospice organizations? And this question is for Kim. Kim, as we start Monarch Ranch, one of the biggest hurdles that we have had is explaining how we are different from non-profit hospice organizations.
Oof, you know, hospice or Christus is one of the few remaining non-for-profit hospices. And then about 3 years ago, when we got taken over by, or not taken over, but we had another company join us, we became for profit. And I'm not real sure how that works. I mean, on my end, nothing changed. Do you know much about that, Dr. Yang Kim?
I mean, generally speaking, so every hospice may be run a little bit differently, but generally speaking, I mean, we have guidelines that we have to adhere by. You know, if our patients are on Medicare or, you know, have private insurances. So most hospices abide by the same guidelines. It's become much more regulated now in the past couple of years. So the differences between nonprofit and for-profit, I don't think are as big. But you know, some of the differences could be, you know, because so we usually provide most of the medications that are related to the disease processes that warrant or that contribute to a 6-month prognosis that our patients have. So a lot of that is up to the physician's discretion as well as the whole team that meets together every 2 weeks. So, you know, I would say for the most part, there's no huge differences, but you may find that certain hospices may be run a little bit differently than other hospices, but I don't know if that helps to answer the question.
That's a tough question.
It's a tough question.
All right, this one's from
All
Dominique.
hospices are required. I think all of us do take indigent patients. So we take
Mhm.
non-paying patients. And
Yeah, we just accepted a guest today who's pro, pro bono. What is
yeah,
that called? Charity case. Charity
Mhm.
case. This is a good one from Denise. What are some of the causes of pain as people are dying? I have recently had 2 family members and a close friend on hospice. All have died and wondered about why there is pain.
So there's a lot of different reasons for pain at the end of life. There can be just existential pain, just pain from emotional or spiritual suffering that our patients are going through at the end of life, at the end of their journey. And then there's, you know, physical pain that they're experiencing just because they've been maybe laying in a bed for a long time, and so that can cause a lot of physical or what we would call somatic pain that they're experiencing. Sometimes if the pain medications, if our patients are on very high pain medication doses, then sometimes they can have pain from that. They can kind of become, you know, like the pain medication may not really work anymore, and so they may have a higher pain tolerance or a lower pain tolerance than they had before due to being on very, very high pain medication doses. There can be nerve pain that our patients are experiencing, from their disease process. So there's a lot of different reasons for the pain, but it's commonly something that we see and deal with a lot at the end of life. But we we try to help our patients as best as we can. I think we do a good job.
Yeah, no doubt. This one I think we covered. Is it true that all hospice in Texas do not require DNRs? Uh, or is that dependent on a particular hospice?
I am not certain on the answer for this, but I worked in a previous hospice for several years as well, and we didn't require do not resuscitate orders, and we don't require that currently too. So I would say for the most part, people don't require that because we understand that um, it may take some time for patients to decide
Yeah,
that they want to be DNR.
It's a scary decision
yeah,
to come to. You got to be ready.
right. And last question we have, is it an unrealistic expectation that families will keep the same nurse, especially these days when it's hard to keep people at work?
I don't think so. I think for the most part, at least where we work, we try to keep that nurse in that area, and so you will see the same nurse all the time. Now, if that nurse quits or goes to that's a different story. Um, but like my team works, I do have an LVN that works with me, and so when I don't see my patient for a visit, I may send her, and I like to send her just so they get familiar with her and me, and that way when I'm on vacation like I am now, and she sees them, everybody knows everybody. But for the most part, it should be an expectation that you would keep the same nurse throughout your journey, for sure.
Great. Well, that is our time. When you get the surveys tomorrow, if you have additional questions, I'll have a box where you can list them, and I will get the answers and send them out to everyone if they're lingering questions. But this was just fantastic. I really appreciate you two coming on and sharing your expertise in this way. Next week, the topic is caregiving, the ultimate juggling act. And any of us who have cared for loved ones know how you try to do two things at one time all day long, and it's very difficult. What I love especially about this program for next Thursday, usually caregiving falls to women, but our speakers next week are both men. We have John Vinson of the ABODE staff and Bishop Anthony Obey. And John cared for his first wife until she died, and Bishop Obey cared for his mother until she came to ABODE. So I think it would be really interesting to hear a male point of view on this topic. So I hope that you all will join in. And if you know of men or women who are feeling overwhelmed by juggling or need to know what's ahead in their caregiving, please recommend that they reach out to us, and we'll send them the Zoom link to this program. Let's see what else. Don't forget that we're looking for more volunteers. We'll hope that you join us. And yeah, I think that's it. What a great program. Thank you all so much for your time and your great questions. This will be recorded, and I'll share the link shortly. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Thank you.